which is between a patient and their doctor. The knowledge that whatever information is recorded by the GP, it's confidential and it's kept secure in the medical records held by the practice. Next month, that'll change. Under the controversial legislation passed in 2012, family doctors will be required to pass to a new national database created by NHS England all the medical records of the patients in that practice. This personal GP record will be added to by any other social care organisation who deals with the patient and with hospitals' records that exist for the individual. And this is being done according to National Health Service England to improve the delivery of healthcare and to benefit researchers inside but also outside the National Health Service. I have no reason to suggest that that this move will not lead to improvements in healthcare. And I have no doubt the Minister will deal with that matter much fuller. But I have sought this debate for two main reasons. The first concern is shared by many people, some people present in the room, who have actually considered the security dangers of bringing all this personal data together in one large, huge national database. The second reason is my dismay and even anger at the deliberate manner in which the public have been deprived of consultation and information on what is a significant threat, could be, and I think will be a significant threat to their right of privacy in respect to their medical records. On the first, security, we're assured by National Health Service England that the information will be stored in a secure environment with the highest standards of information governance and technical expertise to protect the data. If patients are reassured by that statement, then the US government must have lower standards. Angela Merkel, for example, the German Chancellor, learned of the fact that the USA were hacking her personal phone from sources inside the US. There was a young lad from Glasgow who was being expedited in the last 18 months to the USA to face charges because from his governed bedroom he had breached military systems in the US. Closer to home this weekend, Barclays Bank admitted that the financial, delicate, sensitive, important financial details of 35,000 of their customers had been stolen.
Does the honourable member believe, as I do, that the single most important point, which I hope he's going to elaborate for us, is whether or not the identities of the people whose data is being stored are also being stored? If they are, they're being stored, then I'm entirely with him. If they are not, if it's only data without identity, then there might be more to be said for this scheme. I'd be very interested to know what he has to say.
George Moody.
I think that's a very important intervention, and I will deal with it because it gets to the nub of the matter. Healthcare improved, fine, but there must be a balance to the right of individuals to have their privacy, and I'll deal with it. The information, I've done that.
On that very point.
Yes.
And it is a very important point because the fear will be not just professional hacking, but actually amateur hacking can break into major databases. But the problem about the medical database is your database is almost as strong as a fingerprint. So if you're looking for me, for example, I've got 5 broken noses on my medical record. That will probably reduce the numbers you're looking at from 60 million to about 100. You could probably work out my age, if that's removed as well, from when I have my diphtheria jab and various other early jabs. So it's still possible to reverse engineer as so-called anonymized data. And in the States, this was done with an anonymized data system in which the governor of Massachusetts' record was picked out by an academic to demonstrate how weak these systems are.
I did read with interest about your unfortunate nose, and I think you make a very important point. I am making the point that there will be an eventual breach of security, which is inevitable with the size of the database, the information stored in there. And the human cost will be potentially disastrous to the patients whose identity and medical history is made public. Careers, I'll be with you in a second, careers could be ended, jobs could be lost, insurance refused, relationships destroyed if sensitive medical facts are made public or are used by private firms or people or indeed the media.
I congratulate the honourable gentleman bringing this matter to the House for consideration. And he's rightly said that medically there is a need to have some of this information, but there's also a fear amongst many patients that the confidentiality that they have may be taken over by money-making ventures from those involved in the process. And does the honourable gentleman feel that instead of an opt-in or opt-out option in the system, that there should be an opt-in? In other words, the GP and the patient get together and discuss the confidentiality and the understanding of the system, whereby before they go forward any system?
Moody. My honourable friend makes a very important point, and it's one that I am intending to make on the second point. I'm dealing with security at this moment, but I will deal with the opt-out arrangements, which are far from satisfactory. A further reason for concern is that the information will not be solely available for analysis and research in the National Health Service, but will be made available to non-HS organisations. A library note gives an describes in interesting terms the sort of situation where, without individuals' consent, the information given can identify the patients. I'll read, in most cases, researchers can carry out their studies using information that does not identify you. Occasionally, however, medical researchers need to use information that does identify you. Our researchers who have obtained your permission or who have been granted special approval are allowed to access your identifiable data. The CAG approves requests where it is not possible to use information that does not identify you and is not possible to ask you. There are a variety of reasons why it might not be possible to ask people, for example, where there are extremely large numbers of patients. So it's okay if they pinch a lot of patients or reveal a lot of patients' information, identify them, you have no comeback because that is reasonable in the eyes of the National Health Service. Another interesting but concerning document is a diagram helpfully provided by the Information Commissioner. They describe 3 different levels of anonymity. The public domain, none, totally anonymous. Approved organisations, NHS, plus outside organisations given permission. Potentially identifiable data. Organisations who have legal basis, the police, all the data, nothing is hidden. And the police, interesting enough, don't have to do what they have to do now, which is get a court order and get the information. They have the automatic right to do it. Another concerning quote from National England explains helpfully that the information given to private researchers would be anonymised before release. However, that is undermined by their statement that the standard of anonymity that they are using requires that they ensure that, as far as is reasonably practicable to do so, information when published does not identify individuals. Now, that's hardly reassuring. All these instances could be dismissed as speculation, but we should be aware that the National Health Service, England and the government see this whole exercise as an opportunity for the UK to become a major player in medical research with both NHS and the private sector having strong economic growth and income from the use of this data. And I left out, by mistake, they are including in this database your National Health Service number, your postcode, your date of birth, your gender, and your ethnicity. Thank you. So there is a considered opinion that with all that, it would be fairly easy, particularly the postal code, to be identifying someone. If I come to the second part, which is the question of permission, this genuinely makes me very cross. The handover from the GPs will take place in March, in a month's time. It will take 3 months, and by then 100% of the records will be on the national database, depending on opt-out numbers. This should have already happened, but the Information Commissioner stopped them from doing it late last year because they had not consulted or given enough information, in the Commissioner's view, to the public. They ordered the NHS to postpone it and to take steps to give more information, which dealt with both what was happening and the right to opt out. They gave £2 million, and they've been given £2 million to have done this, but it's far from clear that they are doing it willingly and they're doing it in bad grace. What has emerged, the summary care, I should mention summary care record. This is another IT exercise carried out 5-6 years ago, more limited in its function, but with the same organisational structure. A key one was that unless a patient objected, their records would automatically go on the database. This tactic of forcing people to opt out rather than in was very successful. And with summary care records, only 1% of the patients in the pilot schemes opted out. There was a suggestion and there was discussion and there was a report done on what system should be used for opting out for this greater system. Surprise, surprise, they chose the opt-out. So with no real publicity, with no real involvement, with no consultation, they are reckoning that that might be the result for the nationwide exercise. And I thoroughly object to that. One of the things they did is they did publish a leaflet. And it's a leaflet that maybe has come through members' doors, but it's a leaflet that is supposedly meeting the Information Commissioner's request, but it is written by, miraculously, a dead author, Enid Blyton, because it's so bland and patronising and uninformative that it's an insult to the general public. Opting out is not actually spelled out. They are demanding that you go to the doctor's surgery, discuss it with the doctor or the practice manager, and then give them their decision in terms of opting out. Somebody taking, you know how, the House knows how busy doctors are, how busy doctor surgeries are. Somebody's going to take a day off work, go to see the doctor, not because they're ill, but because they want to discuss it. It is just not, it's just not sense. So I would suggest that they are not actually serious about involving and empowering the general public. And I think that's the genuinely second reason why real questions should be asked. They also don't make the point that you have 2 opt-out options, one for within the health service and one for giving the information outside the service. You can, or that you can obtain a form, fill it in and send it in to the practice. No, I've said that. Chairman, I really want the Minister, I'm taking up time and I've got a colleague who wishes to come in, but I really do think the Minister should take an example from the Information Commissioner and postpone this introduction to allow further consultations, further discussion about the opt-in, opt-out, about the information that's being, about the security of the information, so that the public, if their medical records are going to be given, have knowledge of it and have had the opportunity to opt out.
George Freeman.
I'll start by congratulating the Honourable Member for Leeds East on raising this debate. I think it merits a bigger attendance, and I hope that we'll get subsequent debates on the floor of the House. It's an important issue. We have seen in recent years and in recent months in this House how data actually sits at the heart of so much of the transparency revolution which is taking place in healthcare, not least in the Francis report, which was indeed in part driven by a revolution in transparency, outcomes data revealing to us differences in outcomes across the UK. And it's highlighted to us that actually within our precious and beloved NHS there are huge variabilities of standards and outputs, and the genie is out of the bottle in the sense of public interest in the power of this data to drive both transparency in terms of outcome and patient empowerment, the theme that he rightly touched on. Mr. Chairman, I come to this, and this would declare particular interest after a 15-year career in medical research, biomedical science and research, the last 7 years of which was helping to create in the National Health Service partnerships between NHS, clinician scientists, research charities, industry and university scientists to try and accelerate the process by which modern medicines are discovered and developed. And it's been my experience that actually quietly over the last 10 years this country has come to lead in some extraordinary benefits for patients in the NHS in the appliance and use of anonymised cohort data sets and indeed specific patient data sets in particular disease areas to drive and accelerate the development of modern medicines. The truth is that the traditional model of medicines development in which we in the NHS have relied for nearly 50 years, in which the pharmaceutical industry goes away and spends hundreds of millions, increasingly billions of pounds, and comes back to us with a perfect drug that suits everybody, is a model that they can't afford and neither can we. And the more we know about genetics and genomics and patients and disease, the more we know that your disease, Mr. Chairman, and mine will be different, and our susceptibility to it is different, and our response to drugs is different. And actually, this revolution of data and research data offers an extraordinary opportunity for the NHS to be the place in the world where we develop and design the 21st century medicines targeted at the patients who need them and generate extraordinary opportunities for our NHS patients and clinicians. I wanted just to mention a particular story which I think brings this to life. The last project I worked on was here in London at King's College with Professor Simon Lovestone, the head of the King's Academic Health Science Centre and Professor of Psychiatry. And the project was funded by the National Institute for Health Research, the NHS body, and was looking at the South London and Maudsley Mental Health Trust catchment, 250,000 patients suffering from a range of mental health ailments. And you'll be aware, Mr. Chairman, that in mental health there is no magic bullet drug. There is a huge cocktail of some very difficult drugs and hugely traumatic experience for patients, often changing drugs, dosage, and it's a very unsatisfactory area of modern healthcare where we're really failing a large number of patients. And the system that was put in place there, funded by the NIHR, created an anonymised data set of the 250,000 patients and allows researchers to look at, across that cohort, relationships between medicines, outcomes, disease, MRA scans, and really shines a light on which drugs are working in which patients, with extraordinary opportunities to help us here in London, in Britain, lead in this next field of developing treatments for a whole range of mental health, from Alzheimer's to a range of other indications. The truth is that this data is utterly key to the quiet revolution of 21st century healthcare and medicine, which I think we are beginning to see. And I think it's key for three things. Firstly, research, as discussed. Secondly, accountability, as we've seen through the Francis report most traumatically, but actually across the board, constituents of mine in Norfolk wanting to understand and see that their patient journey from care to the NHS is properly tracked. And I, as the child of a mother with a power of attorney, wanted this summer to be able quickly to log on and see what she'd been prescribed, what her diagnosis was, when she wasn't in a position to do that for herself. And I think particularly the younger generation are beginning to want and expect the ability to use data to drive accountability. And the third and most important, which is what the Honourable Member touched on, is empowerment. I think we're moving from an age in which healthcare and medicine has been something done to us by government to something that we want modern 21st century citizens to take more responsibility for. So the Minister's touched on a number of concerns. I think a number of them are perfectly valid and worth and important to discuss. I'm under pressure to wrap up very quickly.
My honourable friend makes a fabulously compelling case, and I think I agree with almost everything he says, except one presumption, which is that this is advanced by one all-singing, all-dancing database, rather than a set of tailored, directed ones.
He makes an excellent point, as ever, which I was just coming to. The Honourable Member has raised a number of important points I wanted to touch on. The anonymisation, we should be very clear, this is anonymised data, and I think it might be worth us looking at some sort of framework to ensure that the data that is being released is only anonymised. Nobody is even beginning to think or talk about, nobody has mentioned insurance and anything to do with insurance companies. I think it's important for us to say that here. This is not what this is about. We should all remember that it is illegal for pharma companies to contact any patient. So even if they got hold of any data, that would be illegal. On the question of opt-in and opt-out, I would simply say this. The evidence suggests that patients want their data to be used in research. The Biobank project has seen a 98% opt-in rate. And when you talk to patients, what they say is, are you telling me this data is not being used for research? What on earth are you doing with it? I think there's an additional point which is worth making, which is the confidentiality of doctor and patient. There are layers of data here, and the Honourable Member's broken nose would sit quite high on the fields, but more discrete information, possibly notes made by your GP, that may not be appropriate to release. And I think we ought to acknowledge that there are layers of data that we're talking about. I wanted to wrap up, Mr. Chairman, by saying that I think there is a huge danger that this laudable initiative of the government to link its data sets together to be able to drive this revolution needs on top of it a very clear statement of patient rights, that this is patient data, that patients should have the access and the framework and the architecture to access it for themselves, and that we should be encouraging patients to take responsibility for their outcomes, for their own health, and for their own data. And I think if we did that, we would find that there would be much more public support for this very important, and I welcome this initiative.
Minister.
Thank you, Mr. Hollyburn. It's a pleasure to serve under your chairmanship, and also I'd like to congratulate the Honourable Member for Leeds East on securing this debate, and indeed upon congratulating all members and honourable members for their contributions. In particular, though, I'd like to pay tribute to the remarks made by my honourable friend, the member for Mid Norfolk, who I thought was an excellent speech, highlighting the importance of sharing data to improve patient care. And he talked about empowering patients to take greater control over their health care. That's something that's very important, and key to doing that is making sure that patients have the right data to do so. He also talked about improving research, making sure that we can properly combat disease, find cures for rare diseases, and linking data properly to understand exactly how to do that. And importantly, he also talked about the fact that we need to properly understand how good health services are, recognise where there's good practice, and that's particularly important in the period after the Francis inquiry and the Francis report, which outlined the importance of delivering high quality care and the importance of transparent and properly used data to deliver that. And I think he made those points very well, Mr. Chairman. I will give way. I haven't seen anything controversial yet, but I will...
But my honourable friend also referred to a major project involving people at the Maudsley who'd suffered serious mental illness. What I want to hear from the Minister is that there is no way under the sun that people who have, for example, suffered from mental illness will find their data getting into the wrong hands. Without that guarantee, this project seems very dangerous indeed.
Well, I hope, and I mean, in the time available, it's difficult to speak to what is a very detailed debate, and I apologise, Honourable Member, for that, and I will write to them, hopefully, with addressing some of the points that have been raised. But I can give the reassurance that there are already robust safeguards in place to protect patients with mental illness, and those safeguards will remain just as robust, if not be more robust, under the systems that we will be seeing put in place. But it is important, Mr. Hollybone, to recognise that the big challenge facing the health and care system is the fact that we have, in the past, had too much siloed working, and that's been to the detriment of patient care. We've seen in the past the fact that we have a health system that often, even within itself, has operated in a fragmented and siloed way. We've also seen that the health and care system do not operate in an integrated and joined up manner. And key to driving improvements in patient care is making sure we join up the information that informs what good care looks like. And part of that is about making sure that we have, when we talk about integration, a process for joining up health and care information to say this is what a good integrated care looks like, and this will improve the care that is available for patients. We want to look after people with diabetes, with dementia, with long-term illnesses, and give them dignity of care in their own homes. It's important that we do that, and it's important that we have the right information and the right evidence to do so. And I believe that is a journey we're already well on. The 3.8 billion integration fund will help us do that in terms of the provision of services, and the Health and Social Care Information Centre will help us to get the right evidence base to drive properly joined up integrated care. And of course I'll give way.
Would he confirm that the situation at the moment, i.e. pre this initiative of care.data, is more or less this, that GPs at the moment have the patient records, many of them still actually not electronic, they're in paper formats and treasury tags. There's no formal link across to hospital records. Hospitals will be able to tell you whether a patient has entered and been admitted or not, but they actually don't have an integrated system, most of them, for knowing what treatment your patient got in different bits of the hospital. Normally somebody with a wagon has to push down the corridor and get the treasury tags information. And there's no integration at the moment with the care system. And for many of my constituents, they are, many of them coming in and out of hospital, acute care and community care with chaos actually in terms of data, which makes it very difficult to drive transparency. It was actually one of the things at the heart of the Francis report, some of the Winterbourne View issues, and that is something that I think all of us need to just remember, that this is a really important public health benefit that we would all benefit from.
I think my honourable friend makes some excellent points, and he's absolutely right to highlight the fact that this is what we're talking about here is an evolutionary process. This is not a sudden revolution with the Health and Social Care Information Centre. This is an evolutionary process of better using information to join up care in exactly the way that he describes. It's no good just having a £3.8 billion integration fund to drive better provision of services unless we've got the right information to actually understand what good care looks like and actually join up the intelligence about what that care looks like. And that's exactly what we're looking at doing. But it would be useful, and I will give way very briefly.
The two professionals in the room are having an interesting conversation, but the public want to know, is the Minister content that the data, the personal data, will not lead to identification of an individual? And secondly, is he content with the present system of consultation in terms of opting out?
I am certainly believe we have robust procedures in place that already exist and that will exist under the system that will be in place to protect patients' confidentiality. And I would have, in what would have come on to describe those in detail if I had more time. But it is worth highlighting a little bit of the history. And this is not a revolutionary process to actually have information stored. It's something. This is an evolutionary process. Hospital episode statistics started being collected in the following care settings, I believe in the following years. This is just off the top of my head. 1989 inpatient data, 2003 outpatient data, 2007 to 8 A&E data, and now from 2014 primary care data. So we already have systems for collecting and analysing information. Patient safeguards exist in those systems, and now what we're going to be seeing is a system that joins up and better joins up, builds that evidence base to drive better care for patients, and exactly the points that my honourable friend, the member for Mid-Norfolk, made in his speech, that we need to expand the evidence base, and it's absolutely right that we ensure patient confidentiality in that. I believe we've got the right safeguards to do that. A number of points have been raised in this debate. I will write to honourable members with further clarifications, and I hope that will be helpful. Thank you, Mr. Holliday.
Order. Could I thank all members for taking part in that debate, and I suspend the sitting until 2:30 this afternoon. Order. Order.